Well, good morning, everyone. Thanks for being here. For those of you online, we're certainly happy to have you participate in our tall rounds this morning. For those of you if you're not available, I guess you're not going to be online currently, but this will be available for future review as well for those who have some power outage this morning. So what we're here to discuss today, we have a lot of esteemed members of our lung transplant program, and there's a lot of new and innovative things going on in this field, and we want to give you a little bit of a taste of sort of what's happening in the United States and a bit around the world. In particular, I think some novel and innovative things that we're doing here at the Cleveland Clinic. So our first speaker today will be Dr. Greg Jones. Greg is one of our outstanding cardiothoracic residents and will give us a case presentation.
So I wanted to go over a case. This is a 67-year-old female lung transplant recipient. She's quite short-statured with a height of 4 foot 10 inches, had a significant smoking history over 100 pack years with FEV1 of 22%, COPD and non-obstructive CAD. She had some declining status and increasing home oxygen, about 3 to 4 liters with a Karnofsky index of 60, and she was difficult to match due to her short stature. She was followed by the lung transplant program since 2021 and was listed in April of this year. She became more ill, but again was a difficult match due to body habitus. Her CEAS from July the 23rd was 24.6. Here you can see her recipient imaging. She has severe centrilobular emphysema with bronchial wall thickening and hyperexpansion of bilateral lungs, as you can also see in the chest x-ray to the right. So the donor was an advanced age female from far away in California. Originally, the organ was offered as DCD, but then converted to DBD. The P/F ratio was excellent at 507. It's important to note that we were offer number 143 on the match run list, which meant that 142 patients had declined the organs prior to us. This was also a third-party procurement. Due to the donor age, advanced age, long-distance travel, increased cold ischemic time, and third-party procurement, the decision was made to assess the lungs here at Cleveland Clinic upon arrival and make the decision for EVLP at that time. When the lungs arrived, they did appear favorable for straight transplant, and so we proceeded to the OR. The cold ischemic time was over 10 hours, and the Paragonix lung guard was used during that time to keep the organs between 4 and 8 degrees Celsius. The donor imaging, a little bit hard to tell, but you can see some bilateral lower lobe infiltrates and consolidation as well. In terms of interop details, on the 29th of July, we proceeded with a bilateral sequential lung transplant through bilateral thoracotomy. This was done off pump with the left and right lung warm ischemic times as listed at 9 minutes and 10 minutes respectively. There are no adverse events during the case, and at the conclusion of the case, the patient was on 2 of norepi with a lactate of 5 and minimal vent settings. The patient was extubated on midnight of postoperative day 0 and was weaned to 2 liters nasal cannula by the morning. Pressors were weaned off by that morning as well. On post-op day 1, the patient underwent an awake bronch for cultures. The anastomoses appeared intact. Post-operative days 2 to 3 were focused on immunosuppression, diuresis, and respiratory hygiene. She transitioned to the floor on post-operative day 4. Surgical chest tubes were removed. She was weaned to 1 liter nasal cannula, working on PT and OT. And as you can see, her chest x-ray is well expanded with only minimal effusions and surgical Blake drains. So this case was meant to highlight an advanced age donor from a long distance with a pretty substantial cold ischemic time, but a good outcome for our lung transplant patient.
Thanks for the opportunity. I'll talk to you more about the advanced lung disease that we transplant and the process of referral. When you think about what we transplant, 85% of the transplants fall within the bucket of interstitial lung disease, the advanced pulmonary COPD group, and that falling into alpha-1 antitrypsin deficiency, cystic fibrosis and non-CF bronchiectasis, and the pulmonary arterial hypertension group. Then the remaining 15% of transplants are for the following reasons: sarcoid, Lamb, and Langerhans cell. When would you consider a lung transplant? And this is based on ISHLT guidelines as well as expert opinion. Clinically, physiologically advanced disease where medical or surgical therapy is no longer available. If there's a chance that there's death greater than 50% from the disease without a transplant, you would want to consider transplant. If there's a high likelihood that you would survive 5 years from the transplant, provide a good graft function. When we think about what we're looking for, it's probably easier to think about what we're not looking for. And based on consensus expert opinion guidelines, this is not an exhaustive list, and I don't intend to go through all of this, but when you take a look at it, a patient that's not willing to accept a transplant, that's a pretty good reason not to do a transplant. If they're in septic shock, disseminated infection, HIV, or tuberculosis, if there's malignancy with a high rate of cancer-related death, if there's other significant organ dysfunctions that I've outlined here where a dual organ transplant might not be offered, if there's advanced coronary syndrome or an MI within the last 30 days, if there's untreatable hematologic disorders. But other social, economic factors play into this as well. Folks that are using tobacco, vaping, or IV drugs, obviously, transplant's not a great idea. Limited functional status, non-ambulatory that they can't rehab, and those individuals who have demonstrated non-adherence despite efforts at improvement. Where we fit in with the Cleveland Clinic is we've offered chances to different patient populations that some might consider higher risk or unfavorable risk, and that might fall into this bucket of information here. We won't go through all of it, but what we've seen is patients greater than 70 years, those requiring intervention from coronary disease, the extremes of BMI, the group short telomere syndrome, esophageal dysmotility, chest wall deformities. We are pretty much still on the fence about particular infections like Mycobacterium abscessus, Burkholderia, Seneca, and Scedosporium species are still no's at our program. Those with limited functional capacity and those requiring a retransplant in less than 1 year, particularly for restrictive clad or antibody-mediated rejection or higher risk candidates. And where we can help and where we really have shown that this group can help patients within this population, you'll see this list here. Similar to what I showed before, but we've demonstrated a capacity to help individuals with cardiovascular comorbidities, coronary disease, prior cardio bypass stentings, as well as those with moderate renal failure, esophageal dysmotilities, prior thoracic surgeries, or even pleurodesis. And we're actually a large center offering individuals a chance at retransplant for obstructive clad. When you think about timing a lung transplant, referral, it takes time. So ideally, it's completed before the patient becomes critically ill or it becomes urgent, although we have a capacity to evaluate patients in-house when they do become urgent. These patients should be referred when they're still able to undergo the standard extensive multidisciplinary evaluation. And an early referral can help modify modifiable risk factors like an obese patient. They can lose weight, leads to a better outcome, or a deconditioned patient can get in pulmonary rehab, become more functional, and lead to a better outcome. But as we have a disclaimer, we say that even though you might refer to a transplant center, it does not guarantee listing for transplant. And the post-evaluation process involves the patient, the family, and the transplant specialist in making a decision, if appropriate, to list. And then we'll go into what the CAS score actually means. When you think about, like I said, the 4 buckets, COPD, IPF, PAH, and CF, they're particular criteria. And for COPD, we try to maximize them medically as possible, but less than 25% FEV1 is definitely a good time to refer them. With IPF, as soon as a radiographic or histologic diagnosis, regardless of PFTs, is identified, they should be referred, and those with autoimmune ILDs with a falling functional status, they should be referred. And additional criteria are shown here. PH is a little bit more tricky, and early consideration for referral should be considered because patients that maximal medical therapy now can really achieve a low-risk status within 6 months, but if not possible, they should be referred for transplant. Anybody with PVOD or pulmonary capillary hemangiomatosis should be referred at the time of diagnosis. And in the CF population, the CF Foundation, in coordination with the transplant groups, have changed the referral guidelines in 2019, referring at an earlier stage of disease to help patients and families better prepare, and it allows time to modify risk factors. This here just shows a diagram of how our CCF transplant referral pathway works, from a new referral coming to our center, screening out those that wouldn't fit criteria, sending through financial, coordinator intakes completed, physician reviews, scheduling, and then of course making the appointments for an evaluation. And then again, it's quite an exhaustive evaluation. We're not going to go through it, but it consists through laboratory testing that you might see here just to get a background of information from kidneys and throughout the body, as well as assessments of current and prior infections, as well as vaccination status. Of course, us as pulmonologists, there will be spirometry, diffusing capacity, 6-minute walks and ABGs, additional imaging, cardiac tests, including cardiac catheterizations of the right and left sides, health maintenance, because many of these patients have never actually seen a doctor or have a solid primary care provider. And so sometimes we're updating cancer screenings. And then lastly, GI screening. And of course, because these patients will eventually be completely immunocompromised, we have to do all the live attenuated vaccines before they start immunosuppression. And then with all that being said, the referral process is really quite easy. Seated in the panel right now is Dr. Marie Budev. Her contact information is here, as well as if you have any questions or concerns, my information is here.
Welcome, everyone. Good morning, and thank you for the opportunity to present. Over the next few minutes, I'm going to take you on a whirlwind tour of the change in the lung allocation in the United States and what this change means, what barriers have come up, what challenges, as well as opportunities for lung transplant programs across the country, including the Cleveland Clinic. I have no conflicts of interest to disclose in relation to this discussion. As Ken mentioned, I was the chair of the OPTN Lung Committee, and this was responsible for the implementation of this allocation change. Our discussion aims are listed here. They're quite robust, so why don't we get started? This is a timeline of the U.S. allocation policies, starting off from 1990 all the way up to the present allocation system to the far right of your screen. This new implementation of the allocation policy called continuous distribution was implemented on March 9th of 2023. But to understand why we had to change our allocation policy to get where we are today, you need to understand what the previous allocation policies had and also lacked. In 1990, when we had our first allocation policy, it really didn't include medical urgency. It was a parking lot. Patients went on the list no matter how sick they were and just waited for an organ transplant. Therefore, it resulted in a lot of mortality on the waiting list. Subsequently, many of you are familiar with the lung allocation system, or the LAS. At that time, medical urgency was incorporated, and there was a great deal of emphasis put on medical urgency. So sick patients would be transplanted. However, it was highly impacted and hampered by geographic distribution, meaning geographic hard boundaries. So you would have a patient of low acuity within a geographic area and a patient with very high acuity or very high medical urgency, but the patient with low acuity would see an organ within that same geography first, and the patient that was sicker would not see that organ, and subsequently you had high mortality rates. And this came to a head in 2017, where there was a court ruling that led to the immediate removal of this geographic area. And I'll go into that in a little bit more detail now. So this lawsuit was filed by a family from New York. They had a patient that was a young woman who was waiting on the list, and they filed a lawsuit against the Department of Health and Human Services to broaden geographic sharing. Basically, in layman's terms, they wanted to get rid of that geographic hard boundary because they felt the allocation policy at that time, the LAS, resulted in the allocation of lungs by a candidate's place of residence and not by their medical urgency. So immediately after that court ruling went into effect, we ended up changing the allocation policy somewhat, a temporary change, where we changed that hard boundary by changing it to a 250 nautical mile radius from the donor hospital where the donor organ was located. That was just a temporary sort of stop. The transplant community recognized that we needed a new framework for allocation, and subsequently, the OPTN adopted continuous distribution as the framework. And basically, this is the geographic boundaries that are removed. It's a systematic removal of boundaries, basically a national allocation system. What it did, it operationalized using medical urgency and geographic feasibility to make it efficient to come up with an allocation policy. So continuous distribution was the new policy that was adopted for all solid organs. Heart is going through their selection of what we call attributes, and I'll go into that in one moment. Lungs were the first organ that were selected to implement and to use this framework. And again, the implementation took place in March of 2023. So the old system had geographic hard boundaries. The new system actually used an overall candidate score to rank candidates, and I'll go into that in more detail now. So this score is called the composite allocation score. It basically determines allocation priority. It's composed of 5 goals that you can see here in blue, and there are attributes for each patient underneath these goals. And what does that mean? That means if you're talking about liver or kidney, or you're talking about heart, you can have different attributes and different goals. This is adaptable to all organs out there. And again, lung was the first organ that underwent this implementation of the continuous distribution framework. At the same time as we were working on continuous distribution and this new allocation, OPOs were under a great deal of scrutiny. As you know, the NASEM report had come out. There were congressional hearings on OPO performance performance, and OPOs were tasked with increasing the number of organs that they were offering, getting more organs out there. So we had a storm happening. We had a new allocation system with a borderless system that was national. We were getting offers from coast to coast, and we had OPOs that had increased their activity. So that presents some really great opportunities for programs like ourselves, but it also created a lot of challenges that we are going to talk about over the next few lectures. So what did we learn from continuous distribution? The one-year implementation report just came out a few months ago. In essence, waiting list mortality rate decreased by 29%. That means less patients were dying on the waiting list or being removed for being too sick. The overall transplant rate increased by 16%, meaning we were doing more transplants. There were a number of lung donors per month increased, of overall 14% increase. This might have been due more to the OPO activity rather than the allocation system changing. But in terms of medical urgency and wait list mortality rate, the sickest patients, that was the highest rate of wait list removals. You would expect that with these very, very ill patients. However, in terms of transplant rate, these sickest patients were getting transplanted the quickest. These patients' median time to transplant, if they were really sick in the highest group, were getting transplanted quicker in a matter of days. If you looked at program size, programs like ourselves, large programs that were doing more than 4 transplants per month, our transplant rates increased. But for programs that were smaller, doing less than 2 to 4 transplants, or really small, doing less than 2 transplants per month, they were facing challenges with this new allocation system. Again, probably related to resources and some of the things that they're able to do, which you're going to hear about what our group does very well. So there were some negative aspects to this allocation system going into effect. We were traveling much further. If you look at DCD donors and brain dead donors, our median distance overall to travel had increased exponentially. Also, in addition, the efficiency in terms of getting organ offers out there and accepting organs, we were actually having an offer go out further in terms of number of centers that had to look at the offer before final acceptance. So that was weighing down the system and bogging down the system. So just in summary, what have we learned since implementation? The benefits of the suppositives are great for a program like ours. There's no geographic boundaries limiting allocation. We're increasing the number of transplants. We're decreasing the number of patients that are on the wait list or being removed from the wait list for being too sick or dying on the wait list. But there are significant challenges that have been posed by this new system, and this is what we're going to focus on in the next few lectures that you're going to hear. We are traveling much more, as I showed you. Our match run efficiency has gone down. We need to improve that. We have increased the cost, not just of travel, but we've increased the cost of using third party, like in the case that was illustrated by the previous speaker. We've also increased costs in terms of our donor coordinators, how many offers that they're seeing, what they're having to juggle. There are a lot of other costs that have gone into effect. So transplant and lung transplant has faced some significant increases financially. I'll stop here and then turn it over to the rest of the speakers, and want to thank my team for all their support.
Ken McCurry, I'm the surgical director of the program. And I'm going to talk to you a little bit about today about sort of what we do here at the Cleveland Clinic to try to meet the need of our patients. As you've heard from Jason, we try to be very aggressive in terms of the patients that we offer transplantation to. As you've heard from Dr. Budev, the playing field in the United States is changing a little bit, but I think we're very unique in some regards in terms of how we approach utilization of what we would consider marginal organs, as well as utilization of ex-vivo lung perfusion strategies to try to get our patients transplanted more quickly, to help them live a better life and a longer life. So there's a lot of need for lung transplantation in the United States. So between 1980 and 2014, over 4 million patients died in the United States of some sort of chronic lung disease. A fraction of these patients get listed for lung transplantation. When I started in this field, 27 odd years ago, too long to think about now. We were doing about 800 lung transplants in the United States. We currently do about 25 to 2,600, so we've tripled it over that period of time. But as you can see, there's still a great deal of need. And although the changes in the current allocation system in the United States have decreased waitlist mortality, even though we're still fairly restrictive, although we're pretty aggressive, if you look at the potential pool of patients that might benefit from transplant, we in the United States list a fraction of those for transplant because of our restrictive listing policies. And part of that has been because of the limitation in donors that have been available. And still in the United States, despite some improvements that Dr. Budev articulated very well, there's about a 15 to 30% waitlist mortality. So part of this is due to sort of ideas that came when this field was evolving in the 1980s, and this was really led by Joel Cooper and Alec Patterson at Toronto, and Alec Patterson ultimately at Washington University in the United States. But this idea of an ideal donor lung. And these are sort of the criteria that were accepted back in that period of time. The first successful lung transplant was done in the 1980s, and through the late 1980s and early 1990s, this is really what we looked for. And this is really a pristine donor. But this did hinder, and it was necessary during that time to sort of optimize outcomes and develop the field, but it certainly hindered the number of organs that we could utilize and offer to patients. Over the years, many programs across the world have contributed to this idea of expanding the criteria and utilizing what previously were considered marginal lungs, and that term marginal is really sort of a moving target. I think things that we certainly considered marginal 25 years ago, now we consider routine to use. We're very aggressive at our program and have contributed to some of this literature as well. So we, much along the lines of what Jason said, we commonly utilize donors well into their 60s and some donors well into their 70s if other things look good. As Greg articulated, we'll sometimes travel long distance even for older donors. Smoking history, which used to be considered taboo, we realized that if we decline all donors with a smoking history, will offer this therapy to a lot fewer patients. So now we look for evidence of smoking-related injury to the donor lungs. And if there is none, typically we'll utilize those lungs with very good outcomes. We and others have recently begun to use donors that are hepatitis C positive. That does result in transmission of hepatitis C to the recipient, but the therapies are very effective now at treating hepatitis C, and this is a routine part of our program. And then we routinely utilize organs with abnormal chest x-rays and CT scans as long as there's no infection, and this was really taboo in years past. And we've contributed significantly in this regard, just demonstrating that in very high BMI donors, we normally see infiltrates and consolidation in the lower lobes, yet we're able to, if there's no infection, we're able to go to look at these lungs and ultimately transplant them and offer these to patients. So despite all of this and this movement toward utilizing more marginal lungs, being more aggressive at our program and across the United States, we still, unfortunately, in the United States, utilize the minority of donor lungs that were potentially available. So of all donors that donate an organ, we currently, across the United States, and there's significant variation region to region, we utilize only about 20% of those donors. And a lot of donors are declined for the reasons I have listed here. So the lungs are edematous, perhaps there's infection or excessive ischemia time, or perhaps the logistics and difficulty getting there make it difficult to use those organs. So we and others in this technology was originally developed by Professor Stigstein in Sweden, have begun to utilize a strategy called ex-vivo lung perfusion. And the idea behind this is that you can take lungs out, put them on a machine, sort of schematically that I've shown on the right here, perfuse them with a solution that has a high concentration of albumin and dextran, so it has a very high oncotic pressure, potentially allows you to remove fluid from the lungs and to do other things to be able to treat these lungs while they're ex vivo, being perfused ex vivo. And we do this for about 3 to 4 hours, and I'll show you our strategy. And this has made a very positive impact on our program. program over the last 6 years or so. So EVLP, as I've articulated, perfusion of lungs, the way we see it is it helps us to increase the donor pool. It does this by allowing us to assess questionable lungs, so lungs that we just don't know when they're in the donor, whether they're transplantable or not. We can bring them back, put them on this machine, and we have the machine that I've shown on the right here at our institution, and we can assess them. We can take marginal lungs and assess those and potentially treat those, and I'll show you a couple of the ways that we do that. And then also allows us to address logistical issues, although there are evolving strategies with regards to storage that may allow us to keep lungs outside the body for a longer period of time. Sometimes we can use EVLP to sort of reset that, and there's data that I mean by that. If we're approaching sort of the limits of cold ischemic time and we put lungs on the device, it sort of resets the lungs to tolerate a second longer ischemic time. So we've sometimes gone up to about 22 to 24 hours with the lungs outside the body with a period of just 3 to 4 hours of EVLP perfusion. And then there's a lot of people, including us, working on ways to actually modify lungs. And this is a bit futuristic, but to be able to use gene transfer, other technologies, potentially to perfuse the lungs for several days, modify them genetically or pharmacologically or other sorts of things to make them less resistant to rejection and to actually improve long-term outcomes. And there's a ton of work going on in this regard, and it's really cool. The idea that we could have essentially rooms or warehouses full of lungs that we could modify for a particular recipient, personalized, and then ultimately transplant those days later. So all of this helps us increase the pool of usable lungs and provides flexibility. So the way we see this is that some of these rejected lungs we can evaluate with EVLP, determine whether they're transplantable or not, and either accept or decline them. And this is really the way we sort of approach this at our institution, our program. If it's a standard donor, we go directly to lung transplant. If there's some question, marginal, something else, we assess. If we're able to do things at the donor hospital to make them better, we'll transplant them directly. If not, we'll bring them back, we'll put them on our EVLP machine, and then make a determination after that utilizing those strategies. And this has made a very positive impact on our program. We do about 40 to 45 of these a year. A lot of these lungs, the majority of these lungs would otherwise not be transplantable, yet we're able to use this technology to improve them, to contribute to our patients and their outcomes. And when we transplant these lungs, the one we do accept after EVLP, the outcomes are outstanding. As you can see, a 30-day survival of 98%, 1-year survival of 90%. This is actually much better than the International Society for Heart-Lung Transplantation 30-day and 1-year survival. So marginal lungs transplanted into recipients, more options, and better outcomes. And we've contributed a lot to this literature here at the clinic. We have a lot of people working on this and have a laboratory based on this, but looking at ways to evaluate lungs on EVLP, techniques with which to assess them and make determinations as to whether they're suitable, and then also therapies. So sometimes if the lungs are edematous, we'll do things as simple as proning them, so turning them upside down on the machine. And that actually has a very positive, beneficial effect in terms of being able to mobilize the edema in the lungs and to reduce the inflammation. So really, truly an evolving field. And I'll just give you a quick video here of sort of what the lungs look like on the device. So in this bubble that keeps them sterile and being perfused with the solution, and as you can see, we can actually ventilate them at the same time. So we can administer pharmacologic agents both via the trachea as well as through the perfusion circuit and do other sorts of therapies like proning, as I discussed. So all of this has contributed, as I stated, quite substantially to our program. And sorry, the numbers cut off on the bottom, but the most recent one on the right, 129 transplants, was in 2023. So we're just one of a couple of few programs in the United States that have consistently been able to offer transplants to 100 or more recipients per year. In utilizing these approaches, we were able to transplant 129 patients last year, which was significantly by far the largest volume of lung transplants performed in the United States last year. So this is, I was formerly at the University of Pittsburgh quite a long time ago now, and Tom Starzl, who's widely regarded as sort of the father of liver transplantation, was there, a mentor of mine. And back in the 70s, when he was developing liver transplantation, at one point they were doing about 600 or 700 liver transplants per year at the University of Pittsburgh. And this Calvin and Hobbes cartoon strip was developed around that time. I wonder where we go when we die in Pittsburgh, because they were doing so many liver transplants. So what we are striving to do here to offer this therapy, lung transplantation, to more and more patients here in Cleveland is we don't want people to die, but obviously things happen, and when they do, hopefully you're an organ donor and your lungs potentially will come to Cleveland.
My talk today is about surgical perspective and current trends in lung transplant. And we recently just looked at our accumulative 30-year experience of lung transplant at the Cleveland Clinic. We got this published back in Journal Transplantation a few years back. And this is the largest single center study from 1990 to 2019, was more than 1,800 patients. In this study, we divided the cohort into 3 eras, which goes along with an ISHLT report published around the same time. And these eras was divided based on some changes in surgical techniques or immune suppression therapies. And also in this report, we looked at evolution of recipient characteristic after implementation of LAS score and how this impacted outcomes, including survival. And as Dr. McCurry mentioned, we continue to have increased volume in our program. And obviously in the last era, we have much more increased volume from 2009 and after. And even after the study cohort time, the last 5 years, we continue to have increased volume even during the COVID years, and becoming #1 program last year. So in this cohort of 30-year experience, we continue to use single lung in addition to bilateral lung. That's helped some of our patients that are candidate with no pulmonary hypertension or RV dysfunction. They have favorable split perfusion of both lungs, and that help us optimize utilization of donor pool and also help more patients on the wait list. On the right side graph, we continue to use DCD donor. And maybe we're one of the few programs that started using DCD straight for transplant if the donor expired within 1 hour and meet our criteria. Looking at the 30-year evolution of recipient characteristics, as Dr. Budev mentioned, after implementation of LAS score, now we have more sick patients on the list with urgent indication for transplant. So age was significantly higher in the last era. Obviously, they have higher allocation score. That also caused shift in the most common indication for transplant. So now we have more fibrotic lung disease patients in the last era compared to COPD was the most common indication early on. And we're doing more complex transplant, redo, dual organs. The wait list and the mortality has decreased, which was the goal of the LAS implantation, but also that pushed more urgent sick patient for transplant. They were being in the hospital on mechanical ventilation bridging or ECMO bridging. This is reflected in more complex transplant procedures, so now more patient required to be done on cardiopulmonary bypass in the last era compared to before. Also, we're forced to do more concomitant cardiac procedures, including CABG or valve repair replacement, and we continue to receive referral for patients that require concomitant cardiac procedure from other that were declined at other programs. Our early outcomes in the last era also got affected by that, so we have more PGD require ECMO after transplant, and that could be related to more utilization of full bypass or exploration for bleeding, and that caused these patients to have more longer hospital stay, ICU stay, had more tracheostomy. But despite all these challenges, we actually kept our early mortality the same in era 3 compared to era 2. Primary graft dysfunctions, of course, the Achilles heel for early outcome of lung transplant, and in established definition of PGD was implemented in 2005 by the ICHLT. So we looked at PGD rates only on the last era from 2009 to 2018, and we can see that high-grade PGD at 72 hours, which is grade 2 or 3, was less than international and national average, as we're going to see in the next slide. Interestingly, and as expected, we see that people with higher LAS score had more association with high-grade PGD than people with lower LAS score. To put our outcomes in the context, this study was published in 2022. This is a multi-center, 10-center study with more than 1,500 patients from the lung transplant outcomes group. They looked specifically at PGD incidence and trends, and their annual rate of PGD, high-grade PGD, was 14% to 38%. Similar to our study, they have observed increased trend of higher LAS score in the last years, bridge to transplant, PGD, and salvage ECMO. We continue to have lower PGD rates in our program even after the cohort of that study over the last 5 years. We still have rates below the national or international average, and a couple of things that help us to do that, which is optimize surgical techniques, and as Dr. McCurry just discussed, having an EVLP in-house assessment of these extended donor lungs. On the left side, this is our survival from the study. In era 2 and 3, the survival was much better to the era 1 midterm survival, and our midterm survival stays compared to the national or international level was 55% survival at 5 years. One last thing, and that came off from that study, when we look at extended donor outcomes versus standard donor, obviously most of the donor we used in the study was from standard donor, but we have a fair amount of number used for marginal donors. And the only thing we observed different between these two was the rate of PGD at 72 hours and the rate of tracheostomy. And that could be related to some patient in the last era were bridged on ECMO or mechanical ventilation. But there was no difference in the rate of ECMO after transplant, airway complication, acute rejection, length of stay, or even hospital deaths. More importantly, the long-term survival, there was no difference between donor we used from standard or marginal criteria, which can make us more aggressive except looking at these extended donor criteria. Then this is something we looked just recently in the last 5 years for over more than 500 lung transplants. We looked at the acceptance sequence of the donor. So our median acceptance sequence was ranged between 12 to 29. And then there is, as Dr. McCurry explained, we have these 3 avenues of these extended donor criteria. They either go straight for transplant when we send our team and look at the lungs in the donor hospital. Sometimes they come for back table evaluation at the EVLP suite, and we have our excellent in-house EVLP team that can look with ultrasound, other tools to tell us if these lungs are acceptable straight or not. And if there is concern, then we put in the circuit. So we have these 3 avenues, and you can see we have fair amount of number of donors that was above 100 sequence. So that means there was more 100 patients from other program on the wait list that got declined for these lungs. One more thing I'm going to touch base about, which is the ongoing discussion of when we do optimized surgical technique, we do it on pump, off pump, and which pump. So recently we look at the outcomes of multiple modality of mechanical circulatory support during lung transplant in a review article. Across the literature, the outcomes of off pump was better than VECMO, and that was better than full bypass. But that could be biased, that recipient who tolerated off pump procedure, obviously they were less sick, no pulmonary hypertension, no RV dysfunction, or no difficult explain. The worst outcome we found across the literature was unplanned mechanical circulatory support, or what we call crash on pump during the transplant. And that usually happens after you implant the first lung, and you may develop PGD in one side, and you have a diseased lung on the other side, then you have a hemodynamic instability and you have to crash on pump. Postoperative complication, there was a trend that it was higher in people who had transplant on a full pump versus VECMO, but there was less focus on the duration of the pump, and does make a difference or not, and this is something we'll talk about next. And also there was a call for randomized trial to look at VECMO routine use or plan use in transplant, and just this year is going to be started a clinical trial, a multi-center from Canada looking at this routine plan VECMO during transplant. Our group looked at duration of pump, and we presented this study at the ICHLT in 2020. So in the last cohort, more than 2008, 2018, we had more than 1,000 transplants. And interestingly, we found that longer cardiopulmonary bypass, more than 3 hours, was associated with high-grade PGD and worse 1-year survival. And that also goes along with literature from the cardiac surgery. When we have pump more than 3 hours, this is when you start having more complication of coagulopathy and pulmonary and kidney dysfunction. Moreover, the incidence of PGD was comparable between the off pump and if you have the full pump less than 3 hours. So you still can do transplant safely on full pump, as other programs routinely do if you still limit the time to less than 3 hours. And then specifically, we looked at VA ECMO during transplant. There's a lot of programs now. There's a trend in the transplant community to use routine or planned VA ECMO during transplant to avoid hemodynamic instability periods or events during the transplant. Also, that allow controlled reperfusion if we have a high-risk donor or recipient for PGD. So recently, we have established a standardized protocol with Dr. McCurry, with our perfusion team, our anesthesia team for using VA ECMO during transplant. And we looked at our data from 2017 to 2020 with more 379 patients, comparing pump to VA ECMO. So as other literature, postoperative complication was higher in full pump versus VA ECMO in terms of bleeding or early mortality, but this was only in the unmatched group. When we did matching analysis, there was no significant difference, although there was a trend for more complication in full bypass. But for sure, there was a clear finding that longer cardiopulmonary bypass was associated with high-grade PGD, while time on VA ECMO really was not associated with any PGD grades. So takeaway points from all these studies I mentioned. We now are treating more sick recipients that are with urgent indication for transplant, some more recipient bridged on ECMO or a mechanical ventilation, and that was reflected in more complex procedures, difficult explants, more sick patients, and also more concomitant cardiac procedures. The two things that we found that help us mitigate the PGD risk is optimized surgical techniques, as we discussed, and also having an EVLP assessment of donor allograft to exclude donor lungs that are not good for transplant. In terms of mechanical circulatory support during transplant, duration matters, especially on full pump versus VA ECMO. So if you have a patient that you have concern about PGD risk or a difficult explant, maybe you should consider using a VA ECMO. And also the worst outcome across all literatures, unplanned pump or crash in ECMO.
This data set just got accepted to JTCVS structural and endovascular intervention, so I put the entire author list here. The first author is MJ, who just started his traditional fellowship at Beth Israel in Boston. Briefly, I spent a lot of my, percent of my effort in TAVR, so I think it's inevitable I would give this presentation someday. Essentially, TAVR is clinically effective. However, there's very little written or studied in transplant patients in general and lung transplant patients in particular. Obviously, patients that are either listed for transplant or who have had a lung transplant generally don't fit into a low-risk surgical stratification category. In addition, as you heard, there's increased emphasis on avoiding cardiopulmonary bypass at the time of transplant, so there's some potential advantage to not having to do a simultaneous AVR at the time of a single or a double lung transplant. I view this ability to our institution's ability to look at these patients in this fashion as an outgrowth of the fact that we have both a very strong lung transplant program as well as a very strong TAVR program. In very brief terms, the TAVR program is high volume, high quality, and one of just a few around the country that have 3-star STS ratings. Volume for TAVRs is over 650 a year with inclusion of alternative access TAVRs. So the goal of this study was really to investigate what are some of the outcomes of TAVR in patients with end-stage lung disease that are listed or about to be listed for transplant, and those who have had a transplant. This is a single-center retrospective study at our institution up to calendar year 2020, And we essentially looked at all of the TAVRs performed in a patient who was either pre or post lung transplant. We have a total of 10, although I can say that in the 3 to 4 years after the study period, we've probably got at least another 6 to 8 of them. 5 of the 10 were pre and 5 were post. The indication for TAVR in all of the cases was severe aortic stenosis, and in these cases, the access happened to be all transfemoral. In the patients that had TAVR pre-lung transplant, the majority were male. The mean age was 62 years. There were 3 IPF patients, 1 emphysema, alpha-1 patient who also had end-stage liver disease, and a bronchiectasis ILD phenotype. 4 of the TAVR valves were balloon expanding, 1 was self-expanding. And in terms of procedural outcomes, essentially the procedures went well. There was 1 patient who required a pacemaker due to heart block resulting from the TAVR, but there were no neurologic events, vascular complications, aortic insufficiency greater than or equal to 2+, or mortalities. Length of stay, median of 4 days with a range of 2 to 36 days. Most were brief, and there was 1 that had a month post-TAVR in-house hospital stay. More significantly, I think all 5 of these patients that underwent TAVR did go on to get listed and then also were successfully transplanted. The alpha-1 patient who had concomitant liver disease also had a combined double lung and liver transplant, which went well. And the median interval from TAVR to lung transplant was about 7 months, with a range of about 1.7 up to 26. The remainder of the 5 cases that occurred post-transplant, obviously these were patients that got transplanted, got through their perioperative period, then underwent TAVR at some point. This was, again, an older cohort, 66 years old was the mean age. 2 of them had had a single lung transplant, 3 had had a double, and the majority of these were balloon expanding TAVR valves. In general, it was a few years post-transplant before these patients got a TAVR, so they had sort of by definition reasonable survival, a range of 2.6 to 7.6 years post-transplant. In terms of outcomes, again, there was 1 pacemaker out of the 5. There were no neurologic events or strokes, vascular complications, or mortality. Obviously, this is sort of we have a limited timeline for reviewing the outcomes on these folks, but essentially there was no peri-procedural mortality. There was no need for surgical conversion or bailout for these patients. And within the period of study follow-up, there were no valvular re-interventions needed. Looking at some of these through a longer time lens, there was 1 case of MRSE endocarditis, which was treated only with medical therapy, as the patient had other problems which precluded an aggressive surgical approach. And there was 1 case of TAVR valve stenosis that occurred approximately 4 years post-TAVR, but the patient expired from other reasons before this was addressed specifically. So in summary, what we know so far from a very limited case series is that TAVR is safe and feasible in lung transplant candidates, as well as patients that have undergone lung transplant with severe aortic stenosis. Pacemaker was the most frequent procedural complication, and TAVR should be considered for both categories of patients, but we need to learn a lot about the longer-term outlook on this intervention for this challenging group of patients. I want to thank the study authors and all of the members of both the lung transplant and the TAVR teams. Thank you.
Thanks very much, James. I think that was outstanding. I think that really exemplifies sort of how aggressive we try to be, certainly from a cardiovascular standpoint in patients with coronary disease and valvular heart disease, and offering them lung transplantation as well. Can I, James and Haitham, can one or both of you sort of expand a little bit on sort of how we see cardiovascular disease as it relates to lung transplantation, particularly patients that are referred to us for lung transplantation with coronary disease or valvular heart disease, and how we approach that. So along the lines of what James was just talking about specifically for aortic valve disease.
Yeah, I feel since the implementation of LA score, we have these higher risk patients where cardiac comorbidities, we present sometime with coronary heart disease or valve disease that at our program, we still offer them surgery if they meet our criteria for listing and it's feasible. I've done myself maybe few cabbage with double lung transplant. I think it's feasible. The way I done it before, I did it in the transplant part in VA ECMO, then I switch full pump or stay in VA ECMO and do beating heart on VA ECMO. If it's 1 or 2 bypasses and not too complex with good targets.
Yeah, my comments are that in terms of coronary disease, depending on the circumstances of the individual candidate, both PCI and CABG have been used for coronary revascularization, especially with modern interventional cardiology philosophies regarding the length of DAP that's needed after a PCI, which is now, down to 1 to 3 months as opposed to a year. There are some cases that can be receive PCI for limited coronary disease rather than requiring CABG at the time of lung transplant. Apart from TAVR for aortic stenosis, I think things to look for over the next few years would be some of these novel percutaneous valve devices for aortic insufficiency, which are coming along, even though they're not quite ready for prime time. And some of the other catheter interventions for valvular disease, I'm sure we'll be hearing more about in the next few years.
Yeah, so I think just to put a ribbon on that, we're pretty aggressive. So younger patients with valvular heart disease, we'll offer them lung transplant either with concomitant valve repair replacement or, as Dr. Yoon articulated, perhaps with TAVR ahead of time, specifically with regards to coronary disease. So we see a lot of patients that are declined for coronary disease for lung transplantation, see patients for lung transplantation with coronary disease who are declined for lung transplantation at other institutions. So we try to be very aggressive in that regard. Obviously, we have an outstanding cardiology group here. If patients are stable enough and can wait, then we'll do PCI. If they are not stable enough and need to proceed with lung transplantation sooner, we commonly do concomitant coronary bypass grafting. So in this patient population is probably about 15 to 20% of our volume overall. Of all our lung recipients, we do a cardiovascular procedure. So maybe Jason, Marie, would you guys like to expand a little bit on sort of when to refer and what referring physicians can expect in the referral process?
Well, like I shared earlier on, it's best as soon as you detect someone that has any sort of advanced lung disease to refer early, and we'll be a part of the decision tree to make sure, well, is this a good referral now, or is this someone we can work with you on longitudinally? I think if you're suspecting a lung transplant might be needed as a part of the care plan, please refer early because there could be things that need to be remediated, and the more time we have, the better the candidate could be on the back end.
And just to add to Jason's comments, which are spot on, about 30% of our referrals are turned down at other institutions. So for referring doctors, if you've heard a no from another institution, please reach out to us. Many times these patients can be considered candidates here at the Cleveland Clinic.
Yeah, and maybe just to expand on that a little bit, Maria or Jason, can you guys comment? I mean, I think we generally try to work quite collaboratively with the referring physicians. So both their PCP and their pulmonologist and potentially their cardiologist as well if they have one. But to work with them to try to do our best to help patients. We see a lot of patients from a long distance. We currently have patients waiting for lung transplantation as far away as Maine in Florida, and I think 1 or 2 out west as well. So maybe you could speak to that a little bit.
Yeah, so our program is a little bit unique in the sense that we're able to take patients and they don't have to live in the Cleveland area. They have to live within 1,000 nautical mile distance because of some of these allocation issues. And that makes it really effective and is a central part of our program to work with their local providers, their local pulmonologists, and their referring doctors. So they're actually an essential part of this whole process. And for patients to be able to stay at home or live within 1,000 miles, it makes it more convenient for them. It allows them to continue in pulmonary rehab. But there are patients that will move to the Cleveland area, and we can offer them care here with the pulmonologist in association, again, in collaboration with their local pulmonologist, as well as getting them into pulmonary rehabilitation here.
I think we'll close there. I want to thank everyone for attending, both in person and online. If you have any questions or comments or input, please feel free to reach out to anyone at the table here. So thank you.